Hello to everybody. My name is Dimitri Richter. I will have to replace Professor Zokai on chairing Professor Caitlin Notley on this very interesting point about why the UK has taken a compassionate approach to vaping. Professor Caitlin Notley is a professor of addiction science in Norwich Medical School, and being part of other countries that are not so keen on vaping, I'm really interested on what she will tell us. Please, Professor.
Thank you very much for that kind introduction. So I'm going to talk to you today about why the UK has taken a compassionate approach to vaping. I'm a social scientist by background. I'm situated within a medical school. Because of that situation, I think I have a unique position to be able to explore the cultural and social influences on practices such as vaping for smoking cessation. And considering particularly the consequences of those social and cultural influences on behavioural and health outcomes in the long term. So just a few declarations. I've never taken funding from the tobacco, e-cigarette or pharmaceutical industries. I do lead projects funded by the NHS through the National Institute for Health Research in the UK. Currently in receipt of funding to lead a trial of smoking cessation intervention in hospital emergency departments involving e-cigarettes. Although I've been criticised for being pro e-cigarettes, I am in fact pro-health, pro-choice, and also pro-evidence rather than pro any one product over another. And I want to thank my colleagues, Professor Anne McNeill, Jamie Hartman-Boyce, and colleagues from UCL and Action on Smoking and Health in the UK for some of the data they provided for the presentation today. So I'm going to talk about what the UK approach is to vaping. Think about a little bit of the background. So how did we get to where we are now, considering the cultural and historical context in which UK policy and practice is situated? Our approach in the UK has often been highlighted as progressive and leading the way in terms of tobacco harm reduction. But I want to consider really whether the approach can be considered compassionate, and finally conclude with some of the remaining challenges for tobacco harm reduction. So what is the UK approach? Well, in England, a report in 2016 by the Royal College of Physicians described harm reduction as a strategy used in medicine and social policy to minimise harm to individuals and or the wider society from hazardous behaviours or practices that cannot be completely avoided or prevented. I would add in there the aspect of choice, so not necessarily that individuals are not able to prevent or avoid harm from tobacco smoking, but perhaps sometimes wish to continue to using nicotine in different ways. So in terms of our approach to tobacco control overall, the approach to the permissive approach to vaping is generally seen as additional and complementary to other tobacco control measures, including smoking cessation attempts and prevention of smoking uptake. Harm reduction is also a pragmatic approach. So the harm reduction approach really follows what people are themselves choosing to do. The UK approach is in line with what people are choosing to do anyway. We can see here from recent data that most people are choosing to use an e-cigarette in the general population for a smoking cessation attempt. Not as many people as those who choose to use nothing at all, but many more people choose to use an e-cigarette than nicotine or over-the-counter replacement therapies. So e-cigarettes are a more popular cessation option for the general population than nicotine replacement therapy. E-cigarettes, when they first emerged, were described by Carl Fagerstrom in 2015 as a disruptive technology. They're a consumer product that became particularly popular on the market and excitingly potentially attractive to whole groups of people who may not otherwise have been interested in stopping smoking. So e-cigarettes offer a rapid form of nicotine delivery, And devices, of course, are improving and advancing all the time. We now have the modern pod type device using nicotine salt concentrations that seem to mimic the frequency and the fast delivery of nicotine that users get from tobacco cigarettes better than ever before. From my perspective, I also think e-cigarettes are attractive to people because they can mimic the behavioural and the social actions of tobacco smoking that users have previously enjoyed. And possibly e-cigarettes also meet a social identity need within users. So most current e-cigarette users in the UK state that they've used e-cigarettes for smoking cessation. Data from the Action on Smoking and Health Youth Survey this year in 2021 suggests that 95% of young people aged 11 to 17 who have never smoked have also never used an e-cigarette. So most young people are not taking up e-cigarettes unless they have previously smoked. And this data is supported by our adult surveys as well. So data from the UCL Smoking Toolkit study suggests that only approximately 1% of the general population of adults who have never smoked tobacco are regular e-cigarette users. So what we see in the UK is a convergence of data suggesting that e-cigarette use is almost entirely by adults who have used e-cigarettes in order to help them stop smoking tobacco. Despite this, long-term use of e-cigarettes remains controversial. There continues to be concern about long-term health impacts, and because of this, a reluctance by our healthcare professionals to support long-term use, and still possibly an expectation that users who switch from tobacco smoking to e-cigarettes should eventually go on and quit their e-cigarette use. So the UK approach to policies that are supportive of vaping for smoking cessation are also based on good quality evidence of what is effective for smoking cessation. This is recent data from our Cochrane Living Systematic Review of Electronic Cigarettes for Smoking Cessation. This data was published just this month in September 2021 and shows clearly that in randomised trials comparing nicotine-containing e-cigarettes with the next best available option of nicotine replacement therapy through patches or gum, there was moderate certainty evidence that e-cigarettes are more effective in supporting people to quit smoking than the next best option of nicotine replacement therapy. So our pragmatic approach in the UK follows what the public are doing and is dependent on the evidence of effectiveness for smoking cessation. So we've arrived at the approach that we have today. Public Health England in the UK have each year published commissioned evidence reviews summarising all the available data at the time. In a landmark review in 2015, the evidence concluded that vaping could be considered at least 95% less harmful to health than continuing to smoke tobacco. And this message has been supported and repeated through each year through the thorough evidence reviews. So there's growing conclusive evidence of both the effectiveness and the relatively less harm to health than the comparator of continuing to smoke tobacco. We've reached the stage now where we have a public health consensus on the role that e-cigarettes have to play in smoking cessation and tobacco harm reduction. So our leading public health and health bodies across the UK all agree that supporting people to quit smoking by vaping is an important aspect of our approach to tobacco control. In the UK, when we talk about using e-cigarettes as a behavioural practice, we talk about the impact of that practice as being along a continuum of harm. And this is really critical to emphasise. One of the core aspects of the UK approach is the insistence of always comparing the relative harm of e-cigarettes to that of tobacco. No one in the UK is suggesting that vaping is safe. What we do suggest, however, is that in comparison to tobacco smoking, the practice of vaping is considerably less harmful to health. And this positions vaping clearly as a harm reduction option. It is a positive choice that people addicted to nicotine can make in order to improve their health by switching away from smoking harmful tobacco. And this rhetoric also suggests that there are, of course, other potential choices that may be engaged with. So snus, heat not burn or chewing tobacco, for example, may also be other important harm reduction practices, although much less common in the UK at present. In the UK, we attempt to take a clear and transparent approach to the way we communicate with the public about our approach to vaping as a harm reduction option. So there's clear guidance in the UK for health professionals that they should support and encourage quit attempts using e-cigarettes where that is the patient's choice. The NHS give this message clearly on their website. And we have the National Centre for Smoking Cessation and Training with specialist e-learning modules for healthcare professionals on how to support patients to use e-cigarettes for smoking cessation. We have well-publicised public health campaigns. The forthcoming Stoptober campaign, for example, has for a number of years now focused on switching away from tobacco towards less harmful options, such as vaping. And we have had a consultation on our NICE guidelines, which are used by healthcare professionals to guide evidence-based practice. And we expect that the new guideline to be published later this year will be much more clear in the guidance it gives to health professionals to enable them to support patients to use an e-cigarette. And eventually we also hope to see a prescribable e-cigarette that clinicians will be able to recommend to their patients. So the impact of our UK approach to vaping has been, I would say, fairly remarkable. Year on year, we've seen a decline in population level rates of regular tobacco smoking, and around about 15% of the general population of adults at the current time are thought to remain regular smokers. So alongside that declining rate of smoking, we've also seen increasing rates of e-cigarette use. So this clearly suggests to me that ex-smokers are switching away from tobacco towards vaping as an alternative. Of course, we have other tobacco control measures which may also have had an impact on our smoking rates. Smoke-free public places, plain packaging, hidden point of sales displays, for example, may also have had a big impact. But I think looking at this data from across 3 different large cohort studies suggests that vaping has clearly had an important role to play in the declining smoking rates in the UK. However, we still have a long way to go. Data from the Smoking Toolkit study suggests that every year of 100 people who smoke tobacco, approximately 36% try to stop each year. Of those 36%, only 25% or 9 people are abstinent at the 1-year follow-up time point. So this leaves 91 out of every 100 smokers each year who continue to smoke tobacco. And unfortunately, those people who continue to smoke tobacco are mainly from deprived and the most disadvantaged groups in our society. So how did we get here in our approach to compassionate support of vaping and tobacco harm reduction? Well, as well as being pragmatic and based on the evidence, the UK approach has emerged from a specific situated culture and context. In the UK, we've always had a very strong youth culture linked to waves of different music scenes. And each of the music scenes that we've seen over time has been associated quite clearly with some type of substance misuse. The mods in the 1950s, for example, were associated with the use of amphetamines. Britpop and the rave scene of the early 90s was associated with use of hallucinogens and other stimulant drugs. And then the grunge scene was clearly associated with the use of narcotics. Alongside each of these successive youth cultures and music scenes, the UK has developed a clear harm reduction approach. So harm reduction has been used to combat substance use and attempt to make youth culture safer. So not harm-free, but certainly less risky and less harmful. So for example, we've seen needle exchanges and safer injecting practices advocated to reduce the harm from injecting drug use. Harm reduction for people who use recreational stimulant drugs in the UK clubs and rave scene. And of course, harm reduction as a philosophy has extended beyond substance use to encompass things such as promotion of safer sexual practices. From a symbolic interactionist perspective, historically, the cigarette might be considered to have been an item of high social value and key for social exchange. The cigarette can be considered to be iconic in a sense, and really clearly linked to particular youth cultures and subcultural scenes. It can be seen to hold cultural capital, and it's used as an object of consumption and a behavioural practice that displays an identity to others. So this is a powerful tool utilised within group interactions to cement social bonds and signify group belongingness. Being a smoker in cultural times gone by has signified belonging to a particular social group and is associated with an identity ascribed to that group. And cigarettes and smoking have been strongly linked to British youth culture over time. Now, though, that we have e-cigarettes as a disruptive technology, we have the potential to replace this powerful object of symbolic social exchange with something that is also potentially iconic and is ultimately much less harmful to health. So in terms of how we got here, specifically in relation to tobacco harm reduction, the path has really not been linear. Historically, harm reduction within tobacco control has not been conclusive. It wasn't known a few decades ago how best to make cigarettes less harmful, or even if it was possible to do this. Many things were tried, lowering nicotine content of cigarettes, which is a controversial harm reduction option, lowering the tar content, encouraging smokers to adopt safer habits, such as only smoking half cigarettes or switching to different types of cigarettes. And of course, the filter on cigarettes was used as a way of attempting to reduce the harm. So over time, the cigarette industry, manufacturers began working together to try to produce safer cigarettes. This includes things like adding the filters to cigarettes, lowering the tar content, and somewhat confusingly, from a public perspective at least, the lowering of nicotine content in cigarettes, even though we now know that it's not nicotine, of course, that is the most harmful constituent of tobacco smoke. So Professor Mike Russell, who will be very familiar to you all, I'm sure, was heralded really as a man ahead of his time in his thinking on tobacco harm reduction. He's been incredibly influential in our UK understanding of where we've arrived at in terms of our approach to tobacco harm reduction. He was really the first to promote the thinking that smokers, despite being addicted to nicotine, die from the inhalation of tar and not the nicotine itself. He was the first to be really interested in advocating for developing nicotine substitutes as harm reduction options to help smokers quit, and was critical very critical of efforts to reduce nicotine in cigarettes, suggesting that this gave a really confusing and misinformed message to the public and was ineffective, since we now know from good evidence from puffing typology studies that smokers will compensate more by inhaling more deeply, or smoking more to titrate their own blood nicotine levels. So Mike Russell was really the first thought leader to suggest that using nicotine in safer forms could be a long-term, less harmful alternative to continuing to smoke tobacco. This was a big paradigm leap at the time for our culture. Policy up until this point had really pushed smokers towards abstinence as the long-term endpoint for smoking cessation. So the idea of long-term substitution of nicotine suggested that we as a population might accept the possibility of ongoing dependence on nicotine. So this really is a moral issue and taps into moral discourses about whether we should accept dependence and addiction as a part of the human condition or not. And this remains to this day. There remains a divide in public health between those who view abstinence as the ultimate end game, the ultimate goal of tobacco control, and those who view harm reduction, but that need not include abstinence from nicotine as the eventual end goal. So over time, we've seen that nicotine dependence has become medicalized. Nicotine addiction has been seen as a medical problem, and this has allowed us to develop medications to deal with that addiction. Eventually, the pharmaceutical companies developed nicotine replacement therapies as a way to combat this addiction and this medical problem. The concept of nicotine addiction began to stabilise, became part of our health discourse within the UK, and became an accepted part of the treatment paradigm. This meant that nicotine addiction has been treated as a medical issue, an issue requiring treatment. And this removes a sense of individual blame or stigma from the individual smoker, who can see their issue of smoking as a medical condition. So addiction and treatment were written into government tobacco control strategy. And then over time, we've moved away from a focus on abstinence towards harm reduction through our Royal College of Physicians reports. Government reports on comprehensive tobacco control strategies moved away from a focus on abstinence towards harm reduction. And of course, aspects such as smoke-free public places were also adopted at this time. So the point that we've arrived at in the UK is a consensus that the main goal of tobacco control, policy and practice is to reduce the harm caused by tobacco smoking. There is less concern, although still some remaining, about reducing addiction to nicotine in and of itself. And there is less concern, although again, still some remaining, about eliminating the tobacco industry completely. Indeed, some advocates of tobacco harm reduction would suggest that industry itself may actually have a very important role to play in terms of product innovation that has the potential to improve health. So can we consider this UK approach to be compassionate? Well, on the one hand, the UK permissive approach towards vaping could be considered compassionate because it allows nicotine addiction to continue. So users may use nicotine in less harmful ways. Importantly, from a user perspective, there is choice in cessation methods. It's really important to emphasize with vaping that one size doesn't fit all. Some people do really well with nicotine replacement therapy or behavioral support for cessation. Others may do much better by switching to an e-cigarette, and it's important that we have that choice because that allows a compassionate approach to individual needs. We might say that the UK approach has reduced the stigma of nicotine addiction. Seeing nicotine addiction as a medical problem removes the blame from individual users. And we might say that allowing vaping as part of our approach to tobacco control has levelled up some health inequalities, so making harm reduction options accessible to all. However, we know that support to quit smoking is not uniformly taken up across the social divide. So in some ways, we might consider that the UK still has a long way to go before the approach can be considered truly compassionate. So we know in the UK, on the other hand of the compassionate question, that the most deprived populations are still unfortunately the most likely to continue to use nicotine in the most harmful way through tobacco smoking. Clearly, there are strong cultural and social links for some of the subpopulations in our society that mean tobacco smoking continues for those populations. We might consider that tobacco control measures further stigmatise those who are entrenched smokers. So those people who find it particularly difficult to quit smoking as the UK have moved towards smoking being less normalised as a population level behaviour may become further stigmatised and may therefore find it even harder to quit smoking. And there is some suggestion that vaping may also become a stigmatised behaviour or may even be stigmatised for some subpopulations. So the work of my colleague Francis Thirlway from York suggests that e-cigarettes as a harm reduction option for some populations, such as working class men in particular, may not be an option because it may be considered weak or unmasculine to take these kind of options as an alternative to tobacco smoking. And this is clearly an aspect of e-cigarette use that we need to be watchful of. There are a number of remaining challenges in the UK. One key remaining challenge is how we reach those groups of people who continue to smoke tobacco the most. So around a quarter of people with long-term mental health conditions continue to smoke tobacco regularly. And actually up to 45% of those with a serious diagnosed mental health condition are regular smokers. So this means that people with long-term mental ill health are likely to die approximately 10 to 20 years earlier than people who don't smoke tobacco. Most of those lost years of life for people with serious mental health conditions are directly attributable to their tobacco smoking. So there are serious and entrenched health inequalities in tobacco smoking that suggest to me that the UK still has much work to do to ensure that our approach to the population is equal and compassionate. So we need to do more to reach those who are the most likely to continue to smoke tobacco. A major challenge set by the UK government has been an ambitious target to reduce our rates of tobacco smoking prevalence to 5% or less by the year 2030. So clearly looking at our rates of population level tobacco smoking at the moment, we're not on target to reach those ambitious targets. So we need to do more to actively promote long-term nicotine use, which may be helpful in helping to reach those targets. This might mean much more radical intervention. For example, providing free e-cigarettes to those in our society who really cannot afford to purchase even a starter kit so that they might be able to give vaping a go. A major challenge is public perceptions of harm. So one big remaining challenge is the way in which we tackle these public misperceptions. Around a third of young people in this country think that e-cigarettes are as harmful as smoking tobacco. And this is mirrored in the adult population, where harm perceptions are also inaccurate. Again, you can see from the green line here that around a third of UK adults think that e-cigarettes are more harmful than smoking tobacco. And this may be in part, unfortunately, due to sensationalist media reporting that has a huge impact on public understandings and lay discourse. And ultimately, this may impact on vaping uptake amongst those who continue to smoke tobacco. There are unfortunately remaining divides in the field of tobacco harm reduction. So despite a very balanced piece written by ex-presidents of the Society for Research on Nicotine and Tobacco on the risks and benefits of e-cigarettes, there's been considerable backlash to this position. Despite high quality evidence produced by Cochrane reviews on e-cigarettes for smoking cessation, there remain factors within public health who are extremely suspicious and dismissive of this evidence and seem to do everything possible to question the quality of that evidence. So these divides are really unhelpful in ensuring that we have a pragmatic and a compassionate approach to tobacco harm reduction. So to conclude, we've talked about how in the UK we have a tradition of harm reduction, and this stems from our cultural and historical approach to harm reduction across different types of substance misuse and other behaviours. Our approach to tobacco harm reduction seems to have had an impact on tobacco smoking rates, which is extremely positive. So we might consider that the UK approach is indeed compassionate. It offers choice, and it focuses on reducing the harm from tobacco rather than focusing on abstinence from nicotine particularly. But key challenges remain. We need to work to reduce inequalities that remain in tobacco smoking, to tackle public misperceptions of the harm of e-cigarettes compared to tobacco smoking, and we need to continue to work to overcome resistance to the tobacco harm reduction approach. Thank you very much.
Professor, thank you very, very much. A really very interesting question and a very interesting approach. I'm sorry we don't really have the time to continue with further questions. We are 3 minutes out, but one very short question for me. What are the results of this approach? Do you have any measurable results of what is happening to the society? Are people changing? Do you have any idea how they are accepting? I mean, what are the first results giving?
In terms of uptake of tobacco smoking amongst young people now, we definitely see that there is much less uptake amongst young people. I think it's possible to say that tobacco smoking in our population has really become denormalized in the last decade or so. It's not normal in many facets of society to see people smoking tobacco anymore, but use of e-cigarettes or vaping has become much more normalized. So it's much more accepted that people may use an e-cigarette as a smoking cessation option.
Thank you very much. And at this point, I would like to close this session. It was a really excellent lecture, Professor. Thank you very much for being with us, and give to the next table the round to continue. Thank you.